Hi everyone, and welcome to my presentation. My name is Dr. Tenee Lopez, and I am a PGY3 resident with the Department of Physical Medicine and Rehabilitation at Honor Health in Scottsdale, Arizona. And the second author is John Sollenberger, who is affiliated with Carl T. Hayden VA Medical Center in Phoenix, Arizona. I will be talking about the use of point-of-care ultrasound after electrodiagnostic studies in the case of wrist pain. The reason I chose this topic is because electrodiagnostic testing can often be a useful tool, especially for any chronic upper extremity pain when it's thought to be due to a neurological or neuromuscular disorder. However, during our evaluations, sometimes we're thinking that the etiology may be more musculoskeletal in nature, and hence, if there is access to an ultrasound machine, it can be used at that point to help in finding out the diagnosis when it is again primarily thought to be musculoskeletal in origin. So a little bit about the case is we have a 65-year-old right-hand dominant female coming into our electrodiagnostic clinic for right dorsal wrist pain after a mechanical ground level fall approximately 6 months ago. She had sustained a non-displaced right distal radius fracture, and it was managed non-operatively by her surgeon, and she was placed in a short arm cast for several weeks. At 4-month follow-up, she was seen by her surgeon. However, she continued to have these residual pains, mostly in her wrist, and she also developed some paresthesias during this time course. She was then referred to our clinic for a possible focal neuropathy, with carpal tunnel syndrome being a top differential. So before we get into her electrodiagnostic results, a little bit about her past medical history is that she does have non-insulin dependent diabetes mellitus, lumbar radiculopathy, fibromyalgia, obesity, vitamin D deficiency, renal cell cancer of the clear cell papillary type, hypertension, and hyperlipidemia. Her surgical history, no dates were listed in the EMR system, and they were not asked during her presentation, but she does have a bilateral rotator cuff repair, total knee arthroplasty on the left partial nephrectomy, and breast reduction. Some of the medications that she was taking at this time was baby aspirin, losartan, and insulin. Her allergies are codeine, lyrica, metformin, strawberries, and shrimp. And her family history is notable for non-insulin dependent diabetes mellitus, breast cancer, and prostate cancer. So on her exam, we can see that her vitals are within normal range. She was slightly tachycardic, but again, these values are obtained typically when she is at her primary care physician's clinic, not necessarily at our clinic. She is obese, and she was sitting comfortably, again, no acute distress. For any type of pertinent findings, she did have weakened grip strength on her right compared to her left, and also some notable weakness, especially with right thumb extension at the metacarpophalangeal, but most prominently at the interphalangeal joints on her right hand. Her neurovascular exam was intact, including sensation in all her digits. So we then did proceed with her electrodiagnostic studies. As you can see here at the top, we have her nerve conduction studies and her EMG shown. So upon interpretation, she does have some borderline normal to mild median focal neuropathy. As we can see that more in that conduction velocity on the median nerve, it is slightly reduced compared to normal values. But otherwise, her motor conduction testing and her EMG results were normal. We then, again, with her high clinical suspicion of likely musculoskeletal pathology, and in this case, an extensor pollicis longus tear, we referred her to our ultrasound clinic, again, which is located in our department, because of this high clinical suspicion. and thus she was able to get in pretty fairly quickly. And as we proceed now to ultrasound imaging, as shown here, we can start off with A, which is the most proximal of the radius. So as we can see here, labeled distal and proximal, and then her starting point is here at the radius, which is labeled R. And the arrow is pointing to the beginnings of the tendon that come into appearance of the EPL tendon. And as we proceed now through images B, C, and D, we're starting to progress more distally. So looking at B, where the arrow is pointing, we can see that there's more of a blunting effect happening and the hypoechoic appearance of the tendon. And then we can also see some effusion that is developing around that tendon sheath there. And as we start moving again more distally, we can see that there's some, again, more expansion and more distension, suggestive of a fluid that is accumulating in that tendon sheath with that anechoic appearance. And as we now go to D, moreover where the carpals are, we can see where this arrow is pointing, that third dorsal wrist compartment just happening to be going over that second compartment with the extensor carpus radialis, longus, and brevis being housed there. And we can just see some irregular appearance of the tendon fibers there. And again, a little bit of edema present there. But again, there was just a lot of irregularities shown in that tendon sheath. So this confirmed more of our clinical suspicion that she has more of a tendon tear or rupture in this case. And this is where we referred her now to an MRI just to confirm our findings. So once she went to radiology for an MRI, as we can see here again, A is more proximally and B is more distally. And these are coronal images, MRI, and we can see here where the arrow is pointing that this is, again, an intact tendon, just deep to the fourth dorsal wrist compartment. And then as we proceed with B, again, this is showing where this is the dorsal aspect and this is the volar aspect in this image. As now we start going through more distally, here at Lister's tubercle, we do not see the normal location where the tendon should be. The EPL tendon should essentially lie adjacent to Lister's tubercle at this level. And we can see also some cortical irregularities going on in this view, which is suggesting of a full thickness tear at near the Lister's tubercle region. And again, upon the final report of the radiologist, his findings were consistent with the full thickness tear of the EPL tendon centered over Lister's tubercle. So with these findings, we then referred her or consulted her orthopedic hand surgeon that had seen her before for further evaluation and discussion of treatment. Eventually, several months out, she was scheduled for an extensor indicis proprius to extensor pollicis longus tendon transfer. And then as we can see here, I put in the time course at 2 weeks, 5 weeks, and 9 weeks post-operatively. She was initially placed in a splint after her initial surgery, and then eventually that was transitioned over through a thumb spica splint. At this point, at her 2 weeks post-operative follow-up, she was again advised to continue her splint wearing for 24/7, except for hygienic reasons. And then she was started on a gentle range of motion program. She still complained of some wrist pain at this point in time. However, as we progress through the weeks post-operatively, her wrist pain actually improved, and she was able to gain some of that motion back with her thumb extension. Her grip strength also improved during this time period, and she was actually told she could advance her activities as tolerated by the 12-week mark and can follow up with her surgeon as needed at that point during her 9-week follow-up appointment. So as we now go into the discussion, so a little bit about rupture of the extensor pollicis longus tendon. It is rare, however, it is a common complication, especially after a non-displaced or minimally displaced distal radius fracture. And there's a lot of studies out there that have different reports of incidences. However, the most recent one I was able to find by Roth in 2012 showed that it can be actually up to 5%. On average, rupture occurs about 6 to 6 point some weeks in some sources after a fracture, but the time range can be very variable, between 2 weeks to 1 year, and is most often seen in women, as we can see also again Roth found in their studies. And there's a lot of hypotheses as to why this occurs. There could be, again, with just given the initial fracture, some bone spicules that are present within the region and can start tearing at the tendon. There's a lot of also localized inflammation happening in a very confined space, which is basically compromising vascular blood flow and also nutritional support to the region. And there's some studies that do show that this region also is known as a watershed portion, and just with a bunch of the injuries and a lot of cascading events that can happen, make it prone to a vascular necrosis of the tendon sheath that will eventually result in the rupture. So there has been some studies, and one of them being Ghazal, that was showing that ultrasound can be useful in these cases. He did look at least 11 patients with suspected EPL tendon rupture, and almost all did have evidence under ultrasound of tendon rupture, with 2 just being tenosynovitis in this case. But he highlights the point that ultrasound can be readily accessible and fairly quick to correctly identify any suspicion of a tendon rupture in these cases. So especially for a patient presenting to an electrodiagnostic study where we're thinking more of a neurological disorder at that point, we can just reach out to an ultrasound machine if we're thinking more it is musculoskeletal in origin. And with all of this, again, getting into the correct diagnosis can then lead us into the correct treatment plan for a patient. In this case, it was surgical intervention with EIP to EPL tendon transfer being the most common. There is some studies that have shown that there's different forms of treatment plans, most of which are surgical. And again, the only way we can get there is by getting to the right diagnosis. So in conclusion, again, it's not uncommon for a lot of patients to be referred to our clinic for something that initially was more musculoskeletal in origin. We did see, again, that there's some evidence of a possible beginnings of a carpal tunnel syndrome, as in this patient. Again, it was borderline normal to mild case, but it did not give enough support, especially with definite weakness of her thumb extension. And thus, given again her high clinical suspicion, having an ultrasound and sonography can help out in these scenarios and actually can serve as a complementary tool to electrodiagnostic testing when we have suspicion of, again, a musculoskeletal pathology being present. So I have the references listed below here, and that is all for my presentation. Thank you so much, and I hope you all have a splendid day.